Good morning to all the respected faculty members, seniors, colleagues and juniors. On behalf of our presenting team, I welcome you all to today's postgraduate combined clinical rounds. In the part 1, we discussed about the basics of blood glucose management and dysglycemia in ICU. Now let's proceed to part 2 of our discussion. So we start with the glycemic management in non-critical setting. This is a classic general ward scenario of a 62-year-old male admitted with acute cholecystitis, known case of type 2 diabetes since 10 years. Medications prior to admission were metformin 1000 mg twice daily and glimepiride 2 mg once daily. Fasting plasma glucose levels of 172 mg per deciliter, postprandial glucose 264 mg per deciliter, HbA1c of 8.7, creatinine of 0.9 and total leukocyte count of 12,000. Now in such patients, the oral agents are stopped and insulin is initiated proactively. We don't wait for the levels to climb to 300. A standard basal bolus correction regimen is indicated as HbA1c of around 8.4 reflects chronic poor control. So in this case, the oral anti-diabetic drugs like metformin and sulfonylureas are held. We initiate insulin according to an estimate of total daily dose of 0.4 into weight of the patient, which is around approximately 28 units per day. Then we divide the total daily dose into 50% is given as basal, like 14 units glargine at bedtime, and the rest 50% is divided into 3 parts before each meals. And then correction plus minus units as per the RBS during charting. As we had discussed last time, this was how we calculated the total daily dose of insulin. For a frail elderly patient with renal disease, estimate total daily dose would be 0.3 units per kg per day. For a general stable patient, 0.4 units per kg per day. For an obese or steroid treated patient, 0.5 to 0.6 units per kg per day. Now this was the guideline based correction scale adapted from ADA 2025 as discussed last time. This correction scale is based on the total daily dose estimate which we take if it is less than 40 units per day, 80 units per day and more than 80 units per day. Now this slide shows how we monitored blood glucose in our department. In this patient, the blood glucose was monitored at 6 points in the day: fasting blood glucose, post-breakfast, pre-lunch, post-lunch, pre-dinner and post-dinner. Here we see the typical inpatient trajectory. The day 1 shows elevated blood glucose readings. Now the key is gradual reduction. We don't over-titrate. We look for symptoms of hypoglycemia or rapid drops in blood glucose levels, and we adjust the insulin doses accordingly. Now here on day 1 we started the patient on basal bolus insulin therapy. On day 2, as we can see, there were no rapid drops or hypoglycemia, so we continued the same regimen. On day 3 we got the near target values, and to prevent the hypoglycemia we reduced the basal dose to 12 units to prevent hypoglycemia. And on the day 4 we had stable glucose blood level readings. So now the aim is, we don't aim for perfect glucose immediately, we go for a safe progressive control. Now this is the second case of a general ward patient, Mr. 61-year-old male, 70 kgs male, known case of type 2 diabetes since 8 years with a history of hypertension and chronic kidney disease. Admitted in general ward with community acquired pneumonia on metformin 1000 mg twice daily and glimepiride 2 mg once daily. On admission, HbA1c was 9.1, RBS around 294 mg per deciliter, eGFRs of 52, and the patient is vitally stable, and the patient has been started on oral semisolids. The blood glucose profile during the stay is around 280 to 330 mg per deciliter. So now in this patient, will we continue oral anti-diabetic drugs or not? So in this patient, we hold the oral anti-diabetic, hold metformin because of the risk of lactic acidosis, as this patient has active pneumonia. We hold the sulfonylureas because of high risk of hypoglycemia and especially with variable intake. DPP-4 inhibitors are safe, but they may be insufficient alone in these high blood glucose readings. And SGLT2 inhibitors we avoid due to risk of dehydration and diabetic ketoacidosis. Now, blood glucose range target will be fasting. We keep around 100 to 140 milligram per deciliter and random blood glucose less than 180 milligram per deciliter. We start the patient for insulin naive and hospitalized type 2 diabetes patient, and here the patient was elderly with CKD, so we calculate the total daily dose estimate with 0.3 units per kg per day, which comes around 21 units per day. We divide the total daily dose, 50% is given as basal and the rest 50% is divided into 3 parts, with each part given as bolus before each meal.
So now we will see more and more patients who are coming to various departments on various OHs, and what we need to understand is, even if we are not they do not belongs to medicine or endocrinology, what kind of or which category of OHA they are taking. So everyone is well versed about metformin and sulfonylurea, but in fact they are. But DPP-4 and SGLT2 inhibitors, everybody may not be aware, especially SGLT2 inhibitor, because now this drug has been shown to be beneficial in terms of heart failure, CKD outcomes, and so on. So most of the patients right now would be on these medications. Why we need to know as a part of a medical trainee and the faculty for different specialty, including surgical specialty, because this is a very important drug that needs to be withheld during the hospital stay. This is not supposed to be given during acute conditions, whether infections or any decompensatory illness, because of the high risk of diabetic ketoacidosis, one thing. And the peculiar thing which we sometimes miss, because we have a typical concept of DK, is that there will be an increased blood sugar. However, SGLT2 inhibitor actually cause euglycemic diabetic ketoacidosis, because the way they work, they will throw out the extra glucose in the urine, so blood sugar will be normal, but there will be acidosis, there will be ketone body. So that is very important thing to remember, especially those working in ED. When somebody is coming to your emergency department with respiratory distress, abdominal pain, nausea, vomiting, and patient is on especially long-standing diabetes and SGLT2 inhibitor, please look for euglycemic ketosis, because blood sugar may be normal, very well normal, 180 to 100, but still patients can have acidosis. And other important thing is the urine ketones may be negative in these cases, so high index of suspicion is very much required in these cases. This is something new which probably we have not read while we were doing MBBS or something, because this is a new drugs, new phenomena, new complications. Thank you.
Next case is of a 24-year-old female, known case of type 1 diabetes since 8 years on basal bolus regimen. She presented with acute abdomen and underwent laparoscopic appendicectomy. Post-op status, the patient has been nil per oral for 48 hours and the blood glucose is fluctuating between 100 to 280 milligram per deciliter. The patient is not in diabetic ketoacidosis and the vitals are stable. Now the clinical concerns which arise in this patient is that, will we continue, in a type 1 diabetic, will we continue the basal and bolus insulin if the patient is nil per oral? So in this patient, as the patient is type 1 diabetic, there is absolute insulin requirement. So if we stop the insulin, there can be risk of diabetic ketoacidosis. The patient is nil per oral, so we stop the bolus insulin, and we stop the basal insulin, but we continue the we stop the bolus insulin, but we continue the basal insulin because there are chances of rapid ketone production if insulin is omitted in these patients. So we continue the subcutaneous basal insulin. 100% of usual basal dose is continued, especially if the patient is stable and is expected to resume meals soon. But if the patient is unstable or is vomiting and the nil per oral status is expected for more than 72 hours, then we start the patient on IV insulin infusion at 0.02 to 0.05 units per kg per hour with dextrose infusion.
because nowadays the type 1 diabetic patients are surviving longer, going into adulthood, so they will present with the usual problems which any other individuals have. So it is not just important to know whether patient is diabetic or not. Please take a decide, or we have to label them whether they have a type 1 diabetes or type 2 diabetes, because it's a common phenomena that sometimes patient is not taking orally, especially in surgical ward because of various surgical issues or post-operative course. We stop all anti-diabetic drugs, fearing that there will be hypoglycemia. But type 1 diabetic is a situation where the insulin is required not only for the blood sugar control but for the survival. So they will need insulin no matter what. However, the dose may be less or high depending on the situation and individual scenarios, but it should not be completely stopped. This has happened including in our hospital, that insulin has been stopped and patient will end up in decay. Just to highlight that, just ask whether they are type 1 or type 2. If especially there is, if no test available, the common sense is the patient is having a young onset, childhood onset diabetes, lean patients, and somebody who is on insulin for a long period of time, think twice or confirm with your seniors or Department of Endocrinology whether we can stop it or not, because that can be a very fatal error. So that is what we want to highlight. So if type 1 diabetes, please continue it. We may discuss about the dose, which is, I think right now we cannot go into detail, but that is the important thing which we want to communicate. Don't stop the insulin. And that applies for any medical illness also. Type 1 diabetes not taking orally, again, in fact, the requirement goes up. And that is what actually we teach our each type 1 diabetes patients as a sick day regimes. They are supposed to increase the doses actually. And that is one of the common cause of admission in pediatric ICU, where patients, child has a fever and does not, or have a vomiting, it stopped eating, mother stopped insulin or family member stopped insulin, ended up in decay, and then typically land up in ICU. So this thing I think very important, which we need to remember.
The next case is of a 32-year-old male, known case of type 1 diabetes, presented in diabetic ketoacidosis. In ICU, the patient has been rehydrated and given IV insulin for 48 hours. Now the patient is vitally stable and tolerating oral feeds and ready to transfer to ward. Now, in this patient, we continue IV insulin for 1 to 2 hours after the subcutaneous dose is given. We always overlap the IV and subcutaneous insulin to avoid rebound ketosis. And we calculate the total daily dose of insulin and then shift the patient on basal bolus regimen in the ward. Now, why transition planning matters? Because the patient is improving in ICU, may no longer need IV insulin. Once oral or enteral feeds resume, the subcutaneous insulin become more feasible. An unstructured transition may lead to glycemic chaos with increased risk of hypo or hyperglycemia. So when do we transition the patient from IV to subcutaneous? Is when the patient is hemodynamically stable, oral or RT feeds have been resumed and tolerated, no patient is not on any vasopressor or inotropic support, and IV insulin requirement has been less than 2 units per hour for 6 hours consistently. Now, how to switch from IV to subcutaneous insulin? How do we calculate the total insulin needed in these patients? We take the average insulin requirement over the last 6 hours when the blood glucose readings have been stable and the insulin infusion rates have been stable. We take that rate and multiply with 24 to calculate the total daily dose. We give 80% of the total daily dose as subcutaneous insulin to avoid hypoglycemia. Then that 80% is split into 50% as basal and 50% as rapid insulin in 3 divided doses or as per feeds. We have to overlap subcutaneous insulin by 1 to 2 hours before stopping the IV insulin. Now, example, suppose a patient has been on IV insulin at 1.5 units per hour for the past 6 hours. So the total daily dose will be 1.5 into 24, which comes around 36 units. 80% of 36 units, around 29 to 30 units, is the total daily dose requirement. We give basal around 15 units of glargine and bolus of 5 units divided into 3 meals. We have to continue RBS monitoring every 6 hourly. Now let's hear from the surgical side. I would like to invite my colleague Dr. Prekshit to take it from here for the peri-operative management of dysglycemia.
Thank you, Dr. Sumedha. Good morning, respected dignitaries and my dear colleagues. So I'm here to discuss a special subset of surgical patients who are basically on RT feed. My colleagues from the neurosurgery department also face the same issue. Uh, so we have a common procedure that we are doing in the department is composite resection for oral cavity malignancies. We have a 58-year-old male who has a squamous cell carcinoma of the buccal mucosa and has undergone a composite resection. We keep our patients on Ryle's tube feeds and they stay nil by oral for roughly more than equal to 10 days, giving the oral sutures time to heal. The complaints from the nursing staff because of the Ryle's tube feed is that there are fluctuating sugars for the patient. There are some pre-feed highs and there are hypoglycemic episodes. So there are fluctuations in the sugars for the patient. As a general old routine, we are following a sliding scale in the wards. So these are the sugar monitoring chart for the patient. As we can see, there are early morning lows, and then we get some pre-feed highs. So the problem we are facing on a daily basis in the ward is that there is no consistent insulin plan, and the insulin that we are giving the patient is basically dependent on the sliding scale. That is a reactive approach to the rising sugars. Plus, there are no correction insulins for the continuous feeding, and also the nursing staff is now very unsure of when to monitor the sugar. So the questions we need to address here is first, what insulin regimen will work best for an RT feeding patient? Second, how can we prevent these hypoglycemic episodes even when the feeding is stopped? And how often should the sugars be monitored? I'd like to call upon Sumedha to discuss the management.
Now we discuss the insulin strategy during RT feeding. So this was a 58-year-old male, 60 kgs weight, post-operative nil per oral on continuous RT feeds with history of fluctuating sugars and one episode of nocturnal hypoglycemia. In these patients, we maintain the target goal of 140 to 180 milligram per deciliters, and our goal is to prevent feed-related hypoglycemia and to provide a regimen which is suitable for ward-level cares. Now, insulin strategy, here we calculate the total daily dose estimate of around 24 units in this case. Now, as we saw that the patient had a few early morning hypoglycemic episodes, we divided into 50, like the glargine, it was supposed to be 12 units, but we have reduced it to 10 units to reduce the hypoglycemia. We have divided the bolus dosing on the RT feeds into 4, 4, 4 and 3 units at 6 to 7 am, 12 pm, 5 pm and 10 to 11 pm. The nighttime bolus dosing is reduced to prevent nocturnal hypoglycemia. Now in this patient, when should we monitor the glucose levels? We monitor before 6 am to detect any nocturnal hypoglycemia. We detect every 5 to 6 hours, which will match our bolus insulin timings. We check 2 hours post-feed interruption if there has been any to watch for delayed hypoglycemia.
Because there is no fixed breakfast, lunch and dinner. So everything has to be worked, depends on the timing of the RT feed and the duration of action of insulin. So that is how you will decide the frequency of administration of insulin as well as monitoring of insulin. So typical analog insulin works for 4 to 6 hours. So normally we monitor around somewhere 5 hours every day. So typically you must have seen the sheets which we give. It is like 7 o'clock or 6 o'clock, then 7 o'clock, 12 o'clock, 5 o'clock, 10 o'clock, that's it. Because generally the last meal in our hospital goes around 10 o'clock. So after that we do not give any bolus meal, and in fact last bolus we try to give little on the lower side to avoid the a nocturnal hypoglycemia. So it's basically time based rather than meal, pre-meal and post-meal. Thank you.
Doctor, I just a question.
Yeah.
How do you do the glucose monitoring, whether it is the point of care capillary
Yeah, point of care
prick or
capillary.
continuous?
Point of care capillary, sir.
Why not
Because
why
a
not
CGM
continuous?
has not been approved as such till now for a in-hospital use because of many reasons, including hemodynamic instability, capillary perfusion maybe. It since it measures interstitial fluid glucose, so the principle is different. So FDA-wise, the accuracy is still for outpatient basis. For inpatient basis, it is not approved. Maybe multiple reasons, multiple drugs which may interfere with the sensor technology, the hemodynamic instability. So CGM is still not being used frequently.
Our ICU staff is very well trained for this.
CGM.
For the point of care.
Yeah. Yes, sir.
And they come on the time to do it.
Arterial blood sample as well, sir, but very rarely.
Now, if the patient is on total parenteral nutrition, we add regular insulin to the TPN bag and we start at 0.1 to 0.2 units per gram of carbohydrate.
Just because we are trying to change the profile of the patients by going and expansion. So we will have this question which sir is asking. It's about CGM, though it is not approved, but pump it is approved, especially if the patient is stable enough and motivated enough and educated enough. They can continue their pump during the hospital stay also, as long as the hemodynamic instability is not compromised, and as long as the hospital staff is trained to handle the pump. So probably we will have, the way we are going, we will have those patients who are already on the pump and coming to us with surgery or different procedures. So yes, we have to start training our staff in that direction, because now usages are becoming more and more common, and once somebody is on pump, they don't want every 6 hourly or 4 hourly a prick. So that we need to work upon definitely.
Or now these pumps are coming with the auto mode as well as manual mode. So you can put on the manual mode because patient may be disoriented or something like that, and then the sister can monitor that. No.
There are things which we need to talk about with the. So our staff needs to be trained basically.
Patient comfort point of view, having a finger pricked 6 to 7 times in a day is not comfortable. So can we have a IV cannula through which we can take the sample?
Sir, the glucometer is calibrated for capillary. When we take IV sample, it's a venous blood.
True.
So yes, there will be some issue, but
of
course customization.
The capillary level would be around 10 to 15% higher than the venous level.
Yeah.
But if you can provide the venous testing almost as quickly as the point of care testing, it will save a lot of inconvenience to the patient.
You want to send the sample every 6 hourly or every 6 hourly to lab?
Yes.
That
I mean,
would be
in the interest of patient comfort.
But
I mean, if there are no scientific objections to it.
There is no, of course, though there is no scientific objection, but it's a logistic nightmare for the hospital. For each patient, 6 times samples go to lab, and then the report has to be traced and that to be noted down. And then sometimes patient is having hypo, and you need to act upon.
Rajiv, one question. All these guidelines are for capillary blood samples. No?
Yeah.
If we take interstitial, as about like CGM, interstitial blood is.
CGM is not for hospital. Yes. We do capillary blood.
Capillary, venous and arterial.
Yeah.
Sabhi mein level are different. That's why we use the capillary.
Normally now the glucometer is the way come. They actually calibrate and reflect the venous blood glucose. Always. It's an inherent calibration they do, and they will reflect the venous values.
If the patient is on continuous RT feeds, we use basal insulin and add correction insulin every 6 hours. If the patient is on intermittent RT feeds, we use basal insulin once daily, give pre-feed bolus of rapid-acting insulin before each bolus feed. If the feeds are held for more than 30 to 60 minutes, we hold the pre-feed bolus, and if the nil per oral persists, we start the patient on 10% dextrose IV infusion. Now, the learning points from this case are that the diabetic patients on RT feeding need scheduled insulin, not reactive sliding scales. Insulin must match the feed delivery. Hypoglycemia is preventable if feeds are monitored and dextrose is started early when interrupted, and nursing coordination is the key. Now, some practical tips for the surgical units. We need to write clear insulin orders, what dose, what time, and when to hold, and to hold if the feed is off. Avoid giving insulin without knowing the feeding status. Blood glucose checks must align with the bolus timings, and we need to empower our nursing staff. Now let's come to some of the special scenarios. Now this is a 55-year-old woman, 60 kgs weight with SLE flare on IV methylprednisolone pulses, transitioned to oral prednisolone 60 mg per day with no history of prior diabetes. Baseline fasting glucose was 98 mg per deciliter. Now this is the insulin readings on day 3, day 4 and day 5. Now the interpretation is that as we have given the oral prednisolone in the morning, we see post-lunch peaks which matches the steroid effect pattern. So here we started the patient, we calculate the total daily dose. We give the 50% as 50% as basal insulin and 50% as bolus divided into 3 doses, and give correctional scale as per the ADA guidelines. Now in this patient, as we saw, that we have given unequal boluses, like 5, 6 and 3 instead of equal boluses all the 3 times. This is because we have seen that with this steroid the peak is post lunch. So prednisolone peaks in 4 to 6 hours, so lunchtime glucose surge is seen. So there was highest spikes post lunch, so we gave more insulin bolus at that time. To avoid hypoglycemia at night, as there are lower evening readings because of the steroid fading effect, we give less insulin at dinner time. Now this is a patient, a 66-year-old male, post CABG. Now the patient is post-operatively in ward and oral diet has been resumed. The blood glucose trends now are that the fasting levels are around 160 mg per deciliter and post meal around 240 to 260 mg per deciliter. The patient was not a known diabetic pre-surgery. Now here the stress. Now why are the blood glucose levels elevated? This is because of stress hyperglycemia from myocardial stress. Due to myocardial injury and inflammatory response, there is increase in the counter-regulatory hormones. Plus we have started the patient because of the post-op nutrition. Now in these patients, the target goals will be fasting glucose around 100 to 140 mg per deciliter, post-meal glucose less than 180 to 200 mg per deciliter. We have to try to avoid hypoglycemia, especially in the cardiac recovery period. Now if the patient is taking oral intake, we start the patient on basal bolus insulin regimen and add correction scale until we get stable glycemia. We consider de-escalation to oral agents if post-operatively the sugars stabilize. Now in this patient, if the high blood sugars still persist, we monitor HbA1c before discharge, as it may uncover the unmasked type 2 diabetes, and we plan outpatient follow-up for glycemic reassessment and to add DPP-4 or SGLT2 inhibitors. Now diabetes in pregnancy. This is a 30-year-old woman diagnosed with type 2 diabetes 3 years ago on metformin and glimepiride, now planning conception, with BMI of 28 and HbA1c of 7.2. Now in these patients, why do we need to shift to insulin? Because oral agents, especially sulfonylureas and pioglitazone, are contraindicated in pregnancy. The preconception control prevents congenital malformations and macrosomia, and we aim for an HbA1c of less than 6.5 before conception. So we will stop the oral anti-diabetic agents. We can continue, which is optional, metformin if it is well tolerated and glycemia is borderline. We start the patient on basal bolus insulin regimen. We go for blood glucose monitoring 6 times per day, which is fasting, post-breakfast, pre-lunch, post-lunch, pre-dinner and post-dinner. And we educate the patient regarding meal planning and insulin titration. In most, the total daily dose is calculated in most non-obese women as 0.5 units per kg per day. We increased to 0.6 to 0.7 units per kg per day in patients with BMI of more than 30. The glycemic goals according to ADA 2025 in pregnant women is fasting to be kept at 70 to 95 milligram per deciliter, 1 hour post meal less than 140 milligram per deciliter, 2 hour post meal less than 120, and HbA1c less than 6.5 if safely achievable.
So the targets for pregnancy are different than the targets for a non-pregnant adult when we talk about. They are much more stringent than the non-pregnant adults, male or female, both. So
Targets different for the gestational diabetes and diabetes superimposed on a already diabetic patient during pregnancy.
Targets are more or less same when it comes to during the period of pregnancy. Same fasting is less than 95 pp, 2 hour readings is less than 120, some say 130, and 1 hour reading less than 140. However, because nowadays many of the patients are developing diabetes in young age, and now they are becoming pregnant, or PCOD becoming pregnant. So the whole idea is what practically and patient accept it, then we do transition from OHA to insulin before the planned conception, because that gives us because whenever you make a switch, there is always a time period that is required for stabilization of insulin doses and control. If we do the same exercise after pregnancy, where then it takes around 15 days or a month or so to come to stabilized dose, and that is the first trimester, which is the most important period for fetal effect. So that's the difference, of course. Again, when we plan pregnancy in a pre-existing diabetes, of course the HbA1c we want is very good, that is below 6.5, yeah, not the 7 actually.
Now from pregnancy to labor, the glycemic adequate antenatal.
Of course, there are differences in terms of a long-standing diabetes or diabetics with pregnancy in terms of complication, monitoring, because pregnancy worsens certain complications, especially retinopathy and nephropathy. So someone who is long-standing diabetes like type 1 who is planning pregnancy, then they need to be monitored, especially when it comes to retinopathy part. Retinopathy can worsen during pregnancy.
I think it is important for all the residents to know that pregnancy is a diabetogenic state normally, normal physiologically it is diabetogenic. So some blood sugar level will be definitely increased during a non-diabetic patient also who get pregnant. But you are saying whether patient is having gestational diabetes, that means she was not before diabetic and now developed, and the patient who has superimposed, she was already pre-diabetic and now she has conceived. So the treatment by and large remains same.
Of targets. The only thing is which is important again, nowadays anyway the area is becoming more and more grey, because now many patients are actually diagnosed during the first trimester of pregnancy to have diabetes, because they have never undergone the screening before that. So basically it's a category where somebody who is a known diabetic before pregnancy, then normally what we say gestational diabetes, the typical definition used to be it's the last trimester, 24 to 28 weeks, they used to develop gestational diabetes because of the excessive hormones, which leads to insulin resistance and leads to diabetes. So that used to be typical. Now we are having somebody who is being labeled or diagnosed as increased blood sugar during first trimester. So basically then what we do HbA1c, and if the HbA1c is increased, it means the patient was actually having diabetes before the pregnancy, but they were not aware about it, and that we manage them accordingly. The important difference is typical gestational diabetes, since it happens after 24 to 28 weeks, so they are not at the risk of various congenital anomaly. The risk is macrosomia, increased cesarean section, post delivery hypoglycemia and so on. However, somebody who is who is a known case of diabetes prior to pregnancy, those are the patients who are at high risk of various congenital malformations, because dysglycemia leads to malformation whenever it is present into first trimester of pregnancy. So that will be the difference in various complications that can result from gestational diabetes versus pre-existing diabetes.
Now this patient has presented into labor. Now why labor is critical for glycemic management and intrapartum glucose management? Because of the physiological changes like catecholamine surge and increased cortisol, there is increased insulin resistance and increased glucose levels. Because of the nil per oral status and variable energy demand, there is risk of hypoglycemia. The uterine contractility and the fetal well-being is also affected by the maternal glucose fluctuations. So, now insulin use and technique. Now insulin, the human skin has...
Now, we just included this segment because it's a very genuine issue, and everyone who is whichever branch they belong, everyone is having diabetic patients. Most of them are getting shifted on insulin, and many times it is possible that the staff is not trained because of whatever is the reason. So every resident needs to know that how to take insulin with the pen, because the many times when we receive the call that okay, patient's blood sugars are not controlled, the problem that we always try to increase or decrease the dose or find out whether this regime is working, not regime working, but the problem is somewhere at the basic level, that insulin is being not administered properly. So that is what I think I would request everyone, every resident, the technique should be proper. Otherwise, the whole purpose gets defeated of shifting the patient to insulin and achieving the tighter targets. Thank you.
Now the goal is to deliver insulin into the subcutaneous adipose tissue and not into the muscle. The subcutaneous injection has optimal absorption, but if we give IM, it leads to faster absorption and increased risk of hypoglycemia, and it is even more painful. Now the needle length for insulin delivery, the needle length should be long enough to penetrate the skin and into the subcutaneous tissue, but short enough to avoid the intramuscular injection. So 4 millimeter pen needle is the optimal recommendation for all adults and children with diabetes. It provides reliable subcutaneous delivery and reduces the risk of IM injection. Now skin thickness is relatively constant across all BMIs. The subcutaneous fat layer varies with BMI, especially in lean individuals with low BMI, elderly or pregnant women. They are at greater risk of intramuscular injection. In such patients, a skin lift or skin pinch technique may be very necessary to ensure subcutaneous delivery.
Again, very important, because sometimes we get a call that patient's blood sugars are very, they are fluctuating too much. So especially when patient is lean, thin, children's, and when we are using syringes, not the needle, which is practically possible because not everyone can go for pen. So sometimes we have to stick to the vial and syringes. So there, if we need to be very careful whether we should not land up in injecting into the intramuscular. Otherwise, it will lead to rapid absorption, and with the same dose, which was very well tolerated for the patient earlier, can lead to severe hypoglycemias. So that thing which we need to remember. So we can make a fold and then inject into 45-degree angle rather than 90-degree angle. So these basic precautions can avoid a catastrophic episodes of hypoglycemia, especially in the night.
Now in older adults, the skin is thinner, fragile, and subcutaneous fat distribution changes with age. There are higher risk of lipohypertrophy, bruising and bleeding. Skin lift may help but can be difficult due to dexterity issues. So the decision should always be individualized. In pregnant women, during the first trimester, no significant changes. In the second trimester, usually you should use the lateral abdomen and apply the skin lift. And in third trimester, you should use the lateral abdomen with skin lift and avoid the central areas. In a lean, low BMI patient...
Why avoid central areas?
We try to keep it lateral because we don't want the central part is not the conducive for absorption of insulin because of the presence of rectus sheath and other things. So the same time, so the preferable part is abdomen, lateral side. Then second preferable area is thighs. Please request the staff not to inject on the deltoids, which is again very common practice. We try to always emphasize not to go for there, but somehow that is, we are so used to we do it, but that is the site where the insulin absorption is more unpredictable and most slow compared to abdomen and the thighs. So abdomen is the best, then thighs, and then the shoulder. That is in very, very rare scenario where you cannot approach the area because of whatever reason, maybe surgery or something, burn or something like that.
Now we inspect the site before each injection. We use clean intact skin, avoid scars, stretch marks, tattoos, edema, infection, inflammation or ulceration. Disinfect with alcohol swab in clinical or group settings and let alcohol dry before injecting. Never inject through clothing as it prevents inspection, skin lift and proper penetration. Rotation of sites to prevent lipodystrophy and skin thickening. Then we
में इंजेक्ट थ्रू क्लोथिंग करते हैं क्या?
नहीं sir, नहीं. Now rotation of sites, we divide each site, abdomen, thigh, buttocks or arms into quadrants or halves. We use one zone or quadrant per week. And rotate injections at least 1 centimeter apart, which is around one width of one adult finger, and rotate in a consistent direction. If giving more than one injections at the same time, we use different injection sites. Now this diagram shows the optimal injection site characteristics of the front and back. We have to rotate to prevent lipodystrophy. We divide the injection zones again into quadrants or halves. Insulin should be injected at least 1 centimeter from the previous injections, rotating in a consistent direction. We change the zone regularly, usually one zone or quadrant or half per week. Now proper injection techniques for insulin pens. We have to educate people with diabetes on pen components and safety. Check insulin, the expiry date, clarity for non-cloudy types. Use new needles. Never reuse or use expired ones. We have to remove both the outer and the inner needle covers. Missing the inner cover removal is the common cause of insulin delivery failure, which can lead to risk of hyperglycemia or diabetic ketoacidosis. We always prime the pen, attach the needle securely, prime according to the instructions, confirm at least one visible drop of insulin at the needle tip. This ensures needle patency and accurate dosing. Now we have to confirm if there is sufficient insulin volume in the pen. We dial the desired dose. We use a 4 millimeter needle and 32 gauge needle. Hold the pen perpendicular to skin regardless of skin lift. Injection technique, we insert needle fully into the skin, press the dose button completely and steadily, usually with the thumb, and maintain perpendicular direction. Inject insulin slowly. Wait 10 seconds before withdrawing the needle as it reduces the leakage. Now post injection, we observe the device dose dial back to 0. And how to recognize failed injections is that to recognize leakage, insulin droplets can be seen at the needle tip or the wet skin. And intradermal injection, we can see skin bumps or swelling. Now, if the patient is using syringes are less convenient than pens, but they are still widely used as they are more affordable. And but we require longer or sturdier needles to pierce the vial caps. So the needle length is around 6 to 12.7 millimeter. Needle length recommendations for adults is we can use 6 mm syringe needle. We require skin lift at 90-degree angle if the BMI is 19 to 25 to avoid intramuscular injection. It is not recommended for children less than 6 years. And adults or children with BMI less than 19 because of high intramuscular injection risk, even with skin lift. Now how to draw insulin. Check syringe and insulin, expiry, correct markings for insulin type. Draw air into the syringe equal or slightly greater than the dose. Inject air into the vial. This prevents vacuum formation. We invert the vial, withdraw insulin into syringe and keeping the needle straight. Remove air bubbles, hold syringe upright, tap the barrel and push plunger to expel the bubbles. Post-injection best practices, we remove pen needles after each use, prevents air entry into the cartridge and dosing errors. We avoid needle reuse. Because can lead to loss of sterility, blunted or misshapen needles, which can increase the pain and lipohypertrophy risk. If the reuse is unavoidable, use your own needle rather than skipping insulin. Never share needles between individuals, risk of blood-borne infections.
of insulin is very important, because in a ward there may be 7 or 8 patients who are diabetics, and everyone's insulin is being kept in one fridge in the ward. So again, we have to encourage our staff, though they do it, but we have to just keep a check the label is proper or not, because that is again one of the common cause of error, because everyone is on glargine, so everything appears exactly the same for all the patients. So the proper labeling which we have to ensure as a residents whenever we are working in hospital.
Now, the warning signs for injection technique review: when we need to review if the patient reports unusual pain or unusual lack of pain at the injection site, leaking, bleeding or bruising after injections, need for increased force when pressing the pen button or syringe plunger, delayed insulin or needle refills may suggest needle reuse or improper injection techniques. The clinical red flags are signs of lipohypertrophy or other abnormal skin or tissue changes, and unstable or unpredictable glucose control. Now, insulin storage and handling: the unopened vials should be stored in a refrigerator at 2 to 8 degrees Celsius. We do not freeze or expose to food contamination. Household refrigerators are often outside this range, so we should always check the temperature. Use cooler packs or insulated bags when traveling in hot or freezing conditions. If the vial is opened insulin or in use, we store at room temperature and keep away from direct sunlight and heat. Before injection, we check insulin is not expired and it is clear for clear insulins and properly resuspended for cloudy insulins. Resuspension of cloudy insulin: gently roll or tip the pen or vial until easily
Cloudy
mixed.
insulin means that most commonly what we know is 30-70 or mixed tard or biphasic insulin. So that appears cloudy actually, like a milk, and the normal insulin is direct. It's like water, like this, just transparent. So many of the patients who are already on insulin, and they sometimes take biphasic, and we continue that thing into the hospital. But the important thing is we need to resuspend, because this is a mixture of two insulin. If we do not resuspend, then the proportion is not what is supposed to be ideally recommended, and it will definitely leads to fluctuation in blood sugar. Very common error, very much can be avoidable, but still being done frequently.
We do not shake vigorously because it can cause air bubbles. Allow to reach at room temperature before injection, as it reduces pain and risk of lipohypertension.
Again, encourage your staff to take out the insulin from the freeze or refrigerator sometimes before injecting. Otherwise, what happens is whenever the meal comes, you go to the refrigerator, take out the insulin and just inject it. The cold insulin is actually painful. So most of the time when patients say it's causing pain, it's because of the technical issue or the temperature issue. Otherwise, the 4 mm needle do not cause pain. So that's we need to remember again.